Hello, everyone. We're happy to have this episode today. This is mainly targeted for moms of babies who are premature, preterm, or has spent some time in the NICU. We have three amazing guests with us. Dr. Ulfa, a consultant neonatologist. Dr. Sulaf, who is a certified lactation consultant. Ms. Nihal, who is an early intervention expert and a pediatric and NICU physiotherapist. Thank you, everyone, for being with us. I want to start by asking some questions to Dr. Ulfa. Can you help us by identifying what are the most common challenges faced by the child that goes inside the NICU and for the family as well?
So the NICU means newborn or neonatal intensive care unit. All babies less than 1 month old who needs any support for breathing, for nutrition, any infection immediately after delivery, or even in the first 28 days of life, might be admitted to the NICU. So most of the time we have preterm baby, sometimes extreme preterm baby when they are born less than 28 weeks. But sometimes also term baby who needs like oxygen or feeding difficulties faced or antibiotic. And sometimes even after discharge home, if they need any intensive care, they will be admitted to the intensive care as well. So it's always difficult for the parents to enter the NICU because it's not like it's always stressful situation. The baby is sick. He cannot be admitted in a normal unit. He needs 24 hours continuous monitoring with nurses around and a neonatologist around. So our aim is always to try to explain to the parents as much as possible with simple words what's happening and why this baby needs to stay. Most of the time, unfortunately, we cannot give them like a duration, expected duration of stay, but we will try to update them as much as possible, many times per day sometimes, just to keep them like up to date.
Yes. For parents navigating this journey, I am an NICU mom myself twice. I have 3 children. I navigated this journey 2 times, very different conditions. One of them was a small stay. One of them was a very long stay. So if I'm talking from a parent's perspective, you have a lot of medical jargon and you don't understand what's going on and you don't know what this means. Why is my baby staying? So how do parents like navigate around this medical jargon or understand the baby's condition? And is that stay in the NICU does it always mean that there's something wrong with the baby?
So it's not always something severe. For example, if it's just jaundice and the baby needs a few hours, days of phototherapy, it's not a very stressful situation. Like it's part of the management to avoid complication. But if it's a short stay or long stay, in all cases, it will be stressful for the parents because
you're not going home with your baby.
Exactly. It's always difficult for the mother to go home and keep the baby in the intensive care. This is not what we imagined and the normal scenario. The role of the doctor and nurses also is to try to simplify this medical jargon. It's not always easy. It needs a lot of effort from the doctors and medical staff. But instead of saying, for example, jaundice, we'll say yellow color of the skin, why it's dangerous. And to be honest, so nowadays, I think parents are very clever and they have access to internet. So they will read a lot and they will come back and ask a lot of questions. So we are not like back, I think, I didn't know, I'm young, so I didn't know this time that the parents are not aware of anything and they will only listen to the doctor. Yes. Now they have access to the information. They will ask another doctor, someone from the family, other babies who had jaundice maybe before. Now, if it's a difficult, complicated case, it's becoming more challenging because sometimes even the doctors are still trying to find the reason why this baby is sick. So it's difficult to explain to the parents what's happening and how long the baby will stay.
Yes.
But we are trying as much as possible to simplify things. Immediately after admission, first thing I will explain to the parents what are all these cables, because it's always a shock for the first time when they enter. Lots of cables everywhere. But if you explain to them that those 3 cables are for the heart, this cable on the hand is for the oxygen, the other one is the IV fluid, then they get used to it and they understand everything. The more you explain things, the better.
The better it is.
And the nurses are playing a good role as well because they are there 24/7. The doctor is not always there. And parents can call as many times as they want. If during the night, if they cannot sleep, they can call and just ask, did my baby tolerate the feed? How my baby is doing now?
That's because you're a lovely doctor, keeping people updated.
Yeah, I think it's very important, and I hope that everywhere, all over the world, parents can come anytime and can call anytime. Unfortunately, I know that in some places in the world, still the parents have like limited visiting hours. They cannot come at any time. But in my unit, there is no visiting hours. The parents can come at any time. If they want to stay even all the day, all the night, it's up to them. And if they want to call 10 times during the night, they can call it.
Because the baby also needs that.
Exactly.
You said preterm and premature.
Yes.
So can you explain preterm and premature and what are the risks and the advances now in science that helps those baby make it safely out of the NICU?
So any baby born before 37 weeks is a preterm baby. But the prematurity, like we are trying to divide it in, let's say, 3 stages. Less than 28 weeks, we consider those baby extreme preterm. Between 28 to 32, 34, this is like mild, moderate prematurity. And 34 to 37, it's a very mild prematurity. So most of the time they are doing well, but still, sometimes they still need a lot of support.
Where are they
Before, long time ago, or even in some poor countries, below 26 weeks, for example, they are not resuscitating. But in all like rich country, well-equipped country with the good trained staff, now we are resuscitating even 23 weeks, in some countries even 22 weeks.
And survivor rate?
Yes, we have a good survival rate, but sometimes with more complication, of course. So if the baby is very preterm, like very, very tiny, 23 weeks, 22 weeks, we know that the mortality and morbidity is higher. And every week is important. Like when the baby is like, sometimes we are explaining to the parents, the mother has no choice, she's not the one deciding.
Yeah.
So first thing to tell the mother, it's not your mistake, you didn't do something wrong.
Don't
this
feel
is very
guilty
important.
because you feel
yes. Then, of course, if she can have rest and we can like try
elongate
as much as possible, it's very important for the maturity of the baby. The lungs will be more mature, the brain will be more mature.
So every day inside the womb
Every day counts.
Where is the baby in the development journey, whether extreme mature or just mature or preterm, and what kind of support is expected, and how can you help them develop better in the NICU setup?
Once the baby is outside the womb, we are trying as much as possible to imitate this environment.
Yeah.
So the baby is inside the incubator in a warm atmosphere, cool, like good temperature for to help them to control their body temperature. We are trying to make a small nest to imitate the womb shape, so they feel like boundaries. They don't feel like nowhere in the space. We try to support them. Maybe we'll ask the mother to bring something with her smell, so we can put it next to the baby, so still he will feel the smell of the mother. We are encouraging skin to skin as much as possible.
Does it really help?
Yes, now we have no doubt about this. Like maybe 10, 20 years ago, it was a big debate. But nowadays, I think we have no doubt that skin to skin is a part of the management for the baby.
Back in the days, and that's 10 years ago,
yes,
they would say, if you want to touch your baby, you have to have something between you because you're going to give her infection and this is not good for her. And I would only see her through the box. So
no, that's so difficult. I knew that time because I worked in some units long time ago where it was not allowed, or parents will just watch the baby from, glass.
Yes.
But I think now we have strong evidence and a lot of research about this. It is safe to do skin to skin. Even if the baby actually is very sick, intubated, ventilated, connected to the machine to help him to breathe, it is still good to do skin to skin.
How do you do the skin to skin in that setup?
It's not easy, but you need trained staff.
You
so
just
most of the time, the doctor is there, will give the green light. We need at least 2 nurses because, you have a lot of cables and IV.
But the goal is their skins are
direct skin-to-skin contact. No limits, no clothes, nothing. We just give very few instructions to the parents. You need to take a shower before coming.
So not only mom, parents?
Yes, parents, fathers.
So they also can do the skin to skin?
Of course, yeah. Especially if the mother sometimes is very sick or in intensive care, so the father can start. Yes. And if the baby is not sick, actually we start directly from after the delivery with the father until the mother is recovering. So just like a shower, avoid perfume, do not smoke before, and wear a mask if we have symptoms, and that's it. But wash the hands. Those are the basics to avoid infection. Other than that, for me, there is no contraindication for skin to skin.
What can parents do inside the NICU other than skin to skin, like the sibling, the grandparents?
So they are part of the team.
Yes.
Now we are talking about family-centered care. The parents and all the family is part of the medical team. For me, it's part of it. So we say the baby, the family, the nurses and doctors, and the hospital. This is how I'm seeing it. So the parents are coming before us even. So they have to, if they can, of course, because I know that the life is challenging. Sometimes you have other kids, but they can spend as much time as possible with their baby. Try to bond and connect. Sometimes it could be just a warm touch, putting the hand on the head of the baby and the other hand on the legs of the baby during the care when the nurses are doing some procedure. Just support the baby. The mother can pump her milk even if the baby is not ready to feed directly. So this is very important to be started as soon as possible, and it's very important for the good outcome of the baby. The siblings are welcome if they are not sick and vaccinated, like with a little bit of precautions, but we are allowing in our unit the siblings to come. And if there is no family, we are even allowing the parents to choose one person, trusted person, to come to support them, because we know that it's difficult, tough time. So they need support. Other than that, they can bring some clothes if they want, drawing from the siblings that we can put on the incubator.
And we are makes a difference, right?
Of course, we are celebrating every step. If the baby is don't have any IV fluid anymore, if we are feeding totally, if we remove the oxygen, we are, even the nurses, they love to do this. They will put every month what is the step.
Every achievement counts. Yeah,
Exactly.
it's a long journey.
One of the thing I experienced was what we used to ask parents in India do was that, while you do the KMC, while you're doing the skin to skin, if you wish to speak to the child, you can do that as well. The vibration of the sound,
He recognizes it.
It just calms the child better.
Yes.
The vibration, the touch, the singing, the humming.
Yes.
The humming.
Yes.
Like in India, we use this phrase "om" a lot. Like it's calming for the mother, and that's the reason it will be calming for the child also. Plus the touch, plus the care, plus the body warmth.
Yeah, they know
And
it.
by the way, this is scientifically proven. It's not just a habit. So the baby can recognize the parents and family voices, of course. And most of the research proved that female soft singing voices is even better.
Wow.
So could be the mother, could be the nurses. The nurses are singing sometimes to
They helps the baby develop and calm.
Of course. And some parents prefer to read books, for example.
With
So I see this a lot.
every feed, I know for sure that the nurses also try to hum so that they are
Found the baby too.
yes, so that they are calmer, and then they accept feeds really well.
Yes, so sure. The last big milestone for the parents and the scariest, I am experienced this firsthand, going home and discharge.
Yes. So they are at the same time excited and at the same time scared. And I think our role is to try to prepare the discharge ahead of the time, not one day before discharge.
Yeah.
So usually we have a kind of checklist that the parents can start to learn with the nurses how to change the diaper, how to feed the baby, how to give the medicine like vitamins, iron, all this medication that they have to continue at home. And what we are doing in our unit is that 1-2 days before discharge, we inform the parents, your baby is ready for discharge. Are you ready at home? Do you have everything? The bed, the car seat? We have to do the car seat challenge. So we put the baby in the car seat to make sure that he's tolerating and no oxygen desaturation. And then we will offer them to stay with the baby for a few days.
In the NICU with the baby.
We have rooms next to the NICU. They can stay there. And we will try to make them autonomous.
Yeah.
We will tell them, okay, we are here. Call us if you need us. Of course, the nurse will go and check many times, but we try to let them do everything like at home, so they will be more confident.
Yeah.
And they can stay as long as they want, 1 day, 2 days, 3 days. And most of the time they are ready. They will tell us, okay, now I'm ready. We want to go.
Excited.
Yes. And we will celebrate a big party, okay,
Nice.
trips. Because for us, it's a big achievement. Sometimes if the baby is staying 3-4 months,
You're already attached to the baby and yours.
So we are always attached to the baby, but it's true when they are staying long time, we are more attached.
But you're happy to see them go. Like this is when you.
We are proud of them, proud of the team, proud of the baby and the family, of course.
How important is early intervention during the stay in the NICU
Yes.
and after discharge, from your point of view?
Yes. So for me, it's very important. And
The
it
families
should
are
be-
scared, they're not ready, and they don't
Yeah,
understand.
but I think it's our role to explain to them why it is important. An early intervention could be like even with the nurses, the parents, and then of course the therapists. So it could be physiotherapy to try to help in the mobilization, even if it's passive mobilization for the baby. Avoid to have a flat head because most of the time the baby will be always in the same position. So the nurses are trying to shift the baby, like rotate the baby. But physiotherapy will help a lot. Osteopathy can help. And later on, psychomotricity and speech therapy later on when they are bigger. But of course, it's very important. And I think we all need to be trained, doctors, nurses, to do it. And ideally to have someone like you in the unit.
Do you wait and see, or do you start and see?
Ideally, you have to start and see.
Yeah.
But it's not available in all the units, unfortunately. So we are trying to collaborate with other units.
Dr. Salaf, I personally faced a lot of feeding challenges with my third child. And I want you to tell us why is it difficult, or what are the challenges to breastfeed babies who stay in the NICU, whether they were preterm or had a traumatic birth, or had to like somehow experience the NG tube? Like, why is it challenging to breastfeed?
First of all, I'm really sorry that you went through difficulty time. I just want to tell moms, even a mom who doesn't have a NICU baby, okay, is really struggling. So many moms are struggling with breastfeeding. Why? Because they have a lots of pressure from the society that breastfeeding is natural.
Yes.
Yes, milk will come naturally, but everything around the breastfeeding, pumping is not natural, right? We
Yes.
don't even a tribe anymore. If I was in a Maasai tribe, I would have seen many things and I would learn many things. So imagine a mom in a NICU. Okay, what happens in the NICU most of the time? We have beautiful hospital here with lots of helps, but sometimes the lactation consultant is not really available, and some hospital they don't even have a lactation consultant.
And some mothers, like myself, do not even know that there are lactation consultants that can help you through this journey, whether NICU or not NICU.
Definitely, just for the
How do you help a mother who is finding breastfeeding difficulty? And what are the main challenges that, like problems in latching or food aversions, or
what happens when a baby is in NICU, depending on the stage. Many babies will have doesn't have really correlation with sock swallowing breathing, right?
Yes.
You have to teach them. You have to go from zero. And some babies also are used to bottle feeding. So when you put them on the breast, it's a big challenge. And the third thing is that the mom, most of the time, didn't really stimulate her lactation because she didn't have the help and support to tell her, you need to stimulate your lactation. All the focus is on the baby most of the time, but not on the mom. And I always tell also mom that a mother is born today, not just a baby, and you need to focus on the mom, right? So what shall we do in that case is to really support the mom depending on the stage of the baby and the prematurity of the baby, but to tell her from day one, you need to start stimulating your lactation by hand expression. It's the basics. Because if you don't stimulate your lactation, there is no milk that will come. Your body will not use calories for something you don't ask for, right?
Exactly.
If I don't ask for milk, milk will not come. And many moms, they don't have the info, right?
can you tell the moms how do they stimulate their lactation or
Yes,
maintain the
definitely.
supply?
The first 24 hours, let's say even 12 hours, if you are really separated from your baby, you need to use your hands. So it's a C shape. I push back toward the chest and I compress. I push back toward the chest and I compress. I can do also some massage, circles, but it doesn't have to be painful. And I always ask the staff at the hospital, I tell them, please ask the mom before you touch her breast. Okay, because she was already traumatized.
Yes.
She's
There's
in lots
so
of
much
pain.
trauma, yeah.
Sometimes, physical pain and mental pain. And we'd have to ask her, can I touch your breast? Are you okay?
Yeah.
And if I'm hurting you, please do let me know. So we start with hand expression. And after 12, 24 hours, we need to make sure that she's using, if the baby cannot latch, she's using a good pump. Pumps are like cars. If I need a good pump, because I'm separated from my baby, I need like a medical grade one, a really good one, right? Something that will help a mom to reach her targets.
So being separated from the baby actually affects your milk supply.
Definitely, because you don't have the bonding. First of all, the oxytocin, the hormone of love, that's why we are focusing on skin to skin and kangaroo care, right?
That helps with the milk.
Of course, because the oxytocin is the milk that is pushing your milk out of the breast. It's the hormone of love. Okay, when she is separated from her baby, she doesn't have it. That's why a picture of the baby sometime coming and visiting the baby. Some moms, I don't know if in your hospital it's allowed that they can pump in front of the baby. It's allowed, no? So
You're making me emotional because now I understand. I was separated from my baby and just I really wanted to breastfeed her or at least pump, and I wasn't allowed to see her. I wasn't allowed to touch her, and it wasn't easy. So I always thought, this is my mistake. It's because I'm anxious. It's because maybe I don't love her enough, because, you know, all this guilt that comes and nobody explained it the way you do, that it's the natural progression of having your baby with you, and the skin to skin is what's gonna
100%. But can I tell you something? I always tell my mom, you did the best you could at that moment with the information you had. This is what you have
This is
to
very
tell yourself.
reassuring.
You always have to tell yourself, as a mom, I did the best I could at that moment with the knowledge and information and the limitation that I had.
yes.
Okay? True. So praise yourself for every drop you gave to your baby. Anything you did to your baby is out of pure love, right?
Yes.
So just praise yourself for everything you've done.
Yeah.
This is what I always tell my moms.
And that kind of support of people helping the mother with information is what actually makes them go the extra mile. Because with norms of society and with self like torture and guilt, it must have been my mistake that the delivery happened early. It must have been my mistake that my baby's in an NICU. I can't even feed my baby. So this kind of support and having you around the mom can actually change the journey.
Yes, I wish that we have more and more lactation consultants. And when it comes to pumping, because you were asking me about pumping, I do believe that using the right pump is important, but also using the right flange size. Yes. So what is the right flange size? Today, when you want to buy any pumps in the market, I will not go into brands, but most of the brands, they don't have different flange size. So a mom will end up thinking that I don't have enough milk.
Yes.
But she's not using the right pump or the right flange size. So just let me explain to you, please. How do I choose the right flange size? We have different nipple size, okay? We are all different.
Yes.
At the hospital, most of them will use 24, 27 mm. I never see moms, or rarely see a mom with that type of nipples, like 24. It's huge, right? So let's say this is my nipple. I come here, I measure it. If it's 16, I take 16. If it's 20, I would have to take 20 mm. So focusing on the right flange size will help a mom getting much more milk in less time. We only have one mom and two hands. We have to make this moment the most efficient moment possible. So the right pump, right flange size, and right hands on. So mean that I need to massage my breast while I'm pumping. I have to imagine that my breast is a bunch of grapes, and I don't have a machine to make juice out of it. So I really have to use my hand in a gentle mode to massage my breast. This is where I will get more milk. Okay? And I always reassure a mom, tell her, give yourself some time. It's okay if I see 1 ml, 2 drops, 3 drops, 5 ml. Take a notebook, and just write down everything you're doing and praise yourself.
Yeah, every ml counts.
100%. And what is really important is to stimulate your lactation at least 8 to 12 times in 24 hours to mimic a bit what the baby would have done on the breast.
Yes.
Right?
Yes.
And something to take into consideration here, when a mom has a NICU baby, she's going into lots of stress. As a health professional, I do believe that what is our role is to really acknowledge all the mother emotions without any judgment.
Yeah.
Even if she's telling me, Sulaf, I'm really tired, I don't feel that I can pump now. I'm exhausted. I'm here to support her. I'm not here to judge her, right? But most of our moms today, it's not that they don't want to pump, and because they just didn't have the information. They didn't know what to do.
Yeah.
Right? And they ended up maybe after 1 week, I wish I knew I have to pump more often. I wish I knew I have to use the right flange size.
Yes. Yes. You mentioned kangaroo care. How does that help?
Kangaroo care is above and beyond. It's something that we should implement more and more. I don't know if you heard about a study in Colombia. They didn't have money to buy incubators for babies. It's a beautiful book called the Kangaroo Care book. And what they did, they put lots of premature baby on mother chest.
Yes.
And they realized that, as Dr. Olfa was saying and you were telling, that it's so powerful. Our chest can change temperature depending on the baby's temperature.
Yes.
First of all. Second, it will steady the baby breathe, steady the heart rate. Baby will feel safe and secure. And something that is really powerful, that on our areola as moms, we have something called the Montgomery glands. Those small pimples that create the same smell of the amniotic fluid. Imagine. Oh my God. So it's really beautiful for the baby to be surrounded by that. And the baby doesn't really need the bacteria of the nurse or the midwife or the bed. He needs his mom and dad. Even the dad can do the skin to skin. So for me, skin to skin care should be a must. Whenever it's possible, definitely, but should really be a must.
Yes, this is beautiful.
So if the mother's not able to breastfeed, what options do you give her, and how can you support her not feel guilty about this?
Look, before we think formula, I would tell the mom, I will give her all the information about pumping, hand expression and pumping. If with all those information, she decides to switch to formula feed, I'm also here to support her, right? But what is, I know it's very trendy to say fed is best.
Yes.
I believe that knowledge is power,
Yes.
not fed is best, you know? Do you have the knowledge? Do you have the strengths to go into pumping, hand expression, hands-on? Are you able to do it mentally? I'm here to support you. You can't, we have other options. But instead of also focusing on bottles, depending, Dr. Olfa can say it, but sometimes we can, at a certain stage of the prematurity, maybe we can start introducing something else than a bottle for a baby.
Yes.
Personally, as a lactation consultant, when I see a mom, whenever it's possible, sometimes I teach the baby finger feeding. It's a tube that you put on the finger to activate the suction reflex. Even just the finger inside the baby mouth. For him to learn that I need to suck.
And it starts in the NICU.
Yes, it's sucking.
It starts sometimes with a non-nutritive sac.
Exactly.
So with the finger or the pacifier, we can put breast milk if we have some drops. Or sometimes for painful procedure, we add like a sweet solution to reduce the pain. And it's very important, actually. This non-nutritive sac is the first step to learn how to feed.
Yes.
And until 32 weeks, they cannot coordinate swallowing and breathing. But after 32 weeks, they can. So we can start at that time, even breastfeeding, actually.
Wow.
Yes, as early as 32 weeks.
They have many options. But we just have to inform the mom,
Yes. Yes.
Finger feeding, and then sometime when the mother is back home and she has the baby in the hand, let's say baby is refusing the breast, we can use things like SNS, supplemental nursing system. So it's a tube that I apply on the mother breast to create the same environment as a bottle for a baby to have him back on the breast, So he will be having even the formula or express breast milk on the breast with the tube, so he would be happy with the flow. And this is how we help the baby going back to the breast. Yeah.
It's the simplest thing to start with, so that they are motivated to try use this.
Yes.
Even we see this, that while KMC, while anything, what we used to do is give probably like a sponge or a very clean, soft thing, wherein we dip it in the mother's breast milk, and then just massage. Just massage.
I actually wanted to ask you about the role of the physiotherapist inside the NICU, because usually as moms, we just see you after we get discharged and after we get comfortable, and that could be like when they are 5 or 6 month old corrected. So when does your journey start in the NICU?
How
can you help?
I want to say that I want to advocate participation. Give us the opportunity to participate in the NICU unit. And we, like being a part of the, like ma'am said, member of the team, we will do our bit. We will take care of the, the positioning, the frequency of change of position, which position could be the best for that particular child. Like everybody is in the NICU for different reasons.
How
Every
early?
child.
How early?
I have started intervention as early as 28 weeks also, because by 27 weeks, there are certain assessment tools that can be used to assess the movement, even if it is preterm.
Assess the movement and predict outcome.
Predict outcomes, yes. Like certain tools, like the general movement assessments. The general movement assessment that we do in the NICU, we have been trained and taught to start doing that assessment on term babies till 20 months of age, 20 weeks of age, corrected age. Yes, but the miracle of this assessment is that you can start as early as 28 weeks also.
What do you look
Giving them the opportunity that, yes, I should have started this assessment at 30, but I know that if you are going towards that direction, then I will keep an eye on you, I will do the hand holding for you, and I will provide you the necessary vestibular stimulus so that you reach there. All I want is for any premature baby to try get to that trajectory while everybody else is also helping them clinically. For me to have them, kind of I'll keep a track. I'll keep a track on the
No, but
movement.
explain a little bit about GMA. Like, how can it help parents?
One of my favorite topics is GMA because general movement assessment, like the word says, is assessing the general movement of the child. That's it. I
Not
observe the child.
Observation.
Yes.
Yeah.
It's just I
Videos
observe.
sometimes. Yeah, just videos.
It is so fantastic that I just have to observe the child. What I used to do with my mentor back in India is we used to enter at particular age, at particular week, saying that, I want to see the maturity of movements now because most of the tubes are out. Okay? Now the baby is freely moving. I would not expect the child to be, having so many tubes into him or her and, expect him to move and show variability in movement. No, I wait. I wait till the child is absolutely clinically stable. Yes, but I do see him at that time for positioning, for nesting. So that's the role. I can start as early as 28 weeks if you give me an opportunity.
Inside the NICU.
Inside the NICU.
And this is really rewarding for the family to know, but it's scary as well. So if you see the baby and you observe that there are abnormal movements, then what?
Exactly. That's what we are aiming at, finding things early so that we start the intervention early. I want to highlight the concept here is, there are two things. The maturity of the nervous system and the concept of neuroplasticity. When you let each of this work at its own pace and you stimulate to help it work better, it creates magic. When I say maturity of the nervous system, I specifically say that because the NICU babies are at a stage where, of course, they were supposed to be in the womb. They are now outside. How much ever we try to get them to imitate the womb environment, it's not the womb, and we have to accept that. But having said that, it gives us an opportunity to be able to give them that opportunity, to have that external environment very similar to the womb, so that what are they supposed to do? As a preemie baby, I'm supposed to get the opportunity so that my nervous system matures to its maximum before I get discharged.
So you create that.
You create that environment. That's our job. You create that environment clinically from the doctor's perspective. They do it clinically. We do it manually. The nesting, the KMC, the positioning that we are trying to say is we're just hand-holding the baby in their journey. Let them move towards, the first aim is, yes, survival and maturity to term age. Because then on, it's okay. It's okay. The baby was anyway supposed to come out after 38 to 40 weeks.
Yes.
It will take care of itself. If the maturity is given an opportunity to develop,
The brain will up.
It will catch up. That's it.
And the neuroplasticity is an amazing, actually, new concept. It wasn't known before. But even if, let's say, a baby has a stroke and half of the brain is not working, the other half can compensate. This is what we call plasticity.
Exactly.
So that's why even if you will notice abnormal movement, we will inform the parents, but it doesn't mean that the baby will not compensate.
Yes.
And if we do good early intervention, we will help him to compensate, actually. So it's an amazing concept. So even now, the neuropediatrician, when he will see the baby, he cannot tell the parents the outcome. He said, let's see. we will continue to monitor, observe, and maybe the other part of the brain will take compensate.
Exactly. We have a time span of like birth or prematurity to 3 to 5 years. So this is the space where why be anxious? Just start and see.
But if a baby goes out of the NICU and he is doing well, feeding well, would he still need to see early intervention? Like,
100%.
yeah.
Normally, yes. But it's difficult sometimes to convince the parents because after like 4 months in the NICU, they are finally at home and they don't want to hear about all these interventions anymore.
Exactly.
But I think we need to convince them and explain to them actually the importance of the early intervention. At least, I'll tell them, at least go one time, do first assessment, and then they will tell you how often you need or not to come. Maybe you don't need, maybe you'll just do a follow-up
Absolutely.
every 6 months, every year. And in all cases, the pediatrician, the neuropediatrician, and the therapist will continue to follow the patient and see if he's reaching the milestones and everything is fine. No need. If there is any something detected early, red flag, we will start as soon as possible to avoid complications.
And that is where the developmental pediatrician also, as a team, post discharge, it's not the intensivist that we are actually working with, but most of the time it's our developmental pediatrician that the child visits to. And if they and an early intervention therapist are at par and at a very good understanding that why this child has to be observed, because let's understand one thing, there has been a trauma.
Yes. Something happens.
Something happened. Once you start accepting that, your thought process and your to-do list will involve, the checklist will involve an early intervention therapist just for screening.
Yeah, there are some challenges because there is the insurance problems. It's not always covered by insurance. Parents wants to go back to work and normal life, so maybe they will not have time to bring the child 2-3 times a week for therapy. But again, I think at least start the assessment and then we will adjust the plan according to the baby needs and the parents' life.
Sometimes it's so simple as what we used to do in India is get that screening done while they are in the hospital because it's covered in the insurance. Simple. If that's not possible, there are certain insurances in India that cover those
but you need to have
appointments till
clearance.
3 months. But so we have that much 3 to 6 months of time till post discharge where we can say that this is the tie up, this is where you will find your answers if and when. It's just a guiding force. Just if when you're ready, go for it.
From your experience, tell us like 2 comparative states where you saw the baby and you started intervention, and then you saw the baby and they did not do the intervention and then they came back. Like, how does the prognosis change even if...
Yep. So I will not take names, but I will tell you, like there was baby H, okay? Very dear to us, have been monitoring them remotely. Very simple. Remote monitoring since the time they were born, 2 weeks. Every 2 weeks we monitored them. There are certain general movement assessments that are supposed to mature by, birth to 6 weeks. Then there is certain other movements that are supposed to appear by 12 to 16 weeks. So we have that much time. We gave the baby good amount of time to develop so that we see the next step of movements. And we saw that, at the 6th week also, we saw that this variability is not what I expect from a child that I want to see. If, you want to see more variability in a child has to do a slow dance of movement. No, I don't want a movement to start abruptly and end abruptly.
So it should be
Any
smooth.
grandmother, I'll tell you, any family grandmother can tell you that, this is something different. Why? Because they've seen so many babies.
Yeah.
Yeah.
You need to trust your instinct, to be honest. Mom always knows.
Always. So I would say that, if you don't see smoothness in movement, if you don't see variability in movement, which is what we would see at those ages, you seek help. Send us a video, let us guide you. What we started doing was every week we assessed the video for this child, gave the intervention to the child. We still saw that, a particular segment was not moving the way I wanted it. That's it. There are other signs that you can pick up by positioning a child. Why would a child be, positioning his head to one side? why would I see a child do a, fisting? Why would I see that, the child doesn't take his hand up? You have to get them in so that I don't want to see any kind of a delay. Like, for example, the word delay is a taboo in this country, I feel, because if I say that certain things were supposed to develop at three months, and if it has not developed till 8 months, fine, absolutely, there is a delay, 5 months. But what we are trying to say is, if you met me at 3 months, it could have been achieved by 4
Yes.
or 5. Then there would be no
The gap
delay.
would increase.
Then there would not be any delay. And this is what I vouch for. That's it.
Yeah.
We brought the child in, monitored, started early intervention, 2 weeks or 3 weeks of an intensive, one milestone achieved. He goes back with a very good home program. And then he's like, every time the mother asks me, when do you want me back? When do you want me back? So periodically he attends intensive at home AMC.
Yeah.
And now he's walking independently. So this child, exactly this child, from my joining, I saw this child 2 weeks to 5 weeks, and now I see him walking around the house independently. So this is the journey
Miracle.
of early
Yeah, miracle.
intervention. That's it.
Yeah.
This is where we are saying that, if this is possible for baby H, why cannot be not possible for your
For other
baby?
babies.
That's
yeah.
it.
Coming back to the holistic approach, this is amazing, but it's the same also with the suction and the feeding. So I see many babies are not able also to coordinate suck swallowing
100%.
even at 37 weeks, 38 weeks, because they are not used to. Some babies have a preference on one side more than the other. So, and the mom will have more pain on the left breast more than the right one. So what we are doing now, it's a very holistic approach. So I work with physio, I work with osteo, and moms will see a huge difference. Some moms who didn't want to go to see someone, then they said, I wish I went before.
Yes,
I wish I went before.
Yes.
Because my life changed. I don't
Every
have
time.
any more pain. My baby is able to open wide his mouth now. And you can see completely different tongue movement.
Yeah.
And this is that really can change having a holistic approach can really change the journey, the motherhood journey.
Yes.
Completely.
If you can give the moms a message or what signs to look out for to know that they need help or seek help, what would that be?
I will tell them that you are not alone. We are here to support you. We are not here to judge you. And just follow your mother instinct and it will guide you. This is what I can tell my moms.
Dr. Olfa?
I will tell the parents you are amazing. You are doing your maximum. Don't hesitate to ask all your questions because it's better to communicate than just to keep your worries and questions inside. You are the parents, so you are the one who wants the best thing for your baby, and we are here to all of us to help you and guide you.
100%.
Ms. Nihal?
The only thing we say is, it's like we have come to a point where everything is available in Dubai. Yes, and if we can add something which can benefit your child while the child has had a trauma or not had a trauma, why not?
Yeah.
That's it. That's all we vouch for. Early screening is the need for the hour, just to avoid all those complications
As
that
early as
may,
possible, you know.
may happen or may not happen. That's it. So start early. Wait and watch doesn't work. Start and see always works.
Yeah, I love start and see as opposed to
Because
wait and
that's
see.
where we are at. Any conversation I have had with Amal ma'am early on, if she asks me, you see this child and you see this child 18 weeks or 18 months, what would you see or what would you feel? I always feel, I wish I had seen this child earlier. That is it. Any child who comes to me after 3 years of age also, I feel, I wish I had seen him earlier. That's it. That's all.
Thank you very much for being with us. And I believe that an hour is not enough. So we're going to have more of this where we focus on questions that we get from the parents.
Yes.
But it was lovely, ladies. And thank you very much.
So much. Thank you.